Great. Thank you all for being here. I don't know what the best picture is. Thank you all for being here. I want to talk to you today about distance and how we think about it in pediatric oncology. So my name is Ayesha. I'm a master's student at McMaster University, and my thesis advisor, Dr. Stacey Matterson, and I are investigating this. So this work is grounded in both national data, as well as my lived experience working in emergency medical services in the Yukon Territory. The goal here isn't really to present findings, but it's to invite something differently about distance and how we interact with it in terms of system design. So pediatric oncology in Canada is centralized along the southern belt, as you can see on the map here. And this model exists for good reason, as in like specialization improves outcomes. When you look at the map, you see care concentrated just right along the most southern belt of Canada and vast geography surrounding it. And every time I see this map, as well as a few others in different presentations, it always makes me laugh a little bit because the entirety of the North is not included, even visibly on this map and in other presentations, not calling anybody specific out. But for families living in northern and remote regions, a lot of access depends on referral pathways that cross very large distances. So this map here shows the incident rates across Canada for cancer. And as you can see, they're not concentrated along the southern belt, they're everywhere. And for families living near the regions that have care centers, access may look relatively straightforward, but for families outside of these areas, particularly in the territories or remote regions, care requires coordination across multiple jurisdictions. And while geography doesn't change diagnosis, it does change how families move through the system. So when we talk about distance, we often talk about kilometers, but in practice, distance includes things like travel time, weather variability, seasonal access, coordination between sending and receiving institutions, and it also includes the emotional and logistical realities of relocation. So I'll give you an example. Sorry, I'm a little stressed about the time. I'll give you a quick example. So I, for a long time, worked in medevac coordination in the Yukon Territory. So there's only one major hospital in the entire territory that has one surgeon on 24/7. So not a lot of treatment. And while the surgeon during this time period was working, it was an oncologist, and there was an emergency in this area called Mayo, which is a very small community, about 4 hours drive, a half-hour flight. And there was this child that had a long-term illness and was experiencing an emergent event. And this was in the winter time. So for those of you who don't know, Yukon is light adjusted. So in the summertime, there's about 24 hours of sunlight. And in the wintertime, there's like maybe 3 hours of sunlight. So in this case, there was a definite 3 hours of sunlight available. So this call came in to 911 at about 1 in the morning, and the sun was supposed to come up at about 10 a.m. And this person was experiencing a critical issue that had a time limit associated with a positive outcome. So call came at 1 a.m. There was too much of a snowstorm for these parents to drive in. There were no ambulances available in, honestly, at that point, the entire territory, because the snowstorm required deviations to other communities. And Mayo only had one ambulance with one person who is on an air vent as the operator, so they can't drive with a patient in the back of it. So as you can hear, resources were kind of difficult. So the person had to wait until 10 a.m. the next, I guess the same morning, to see if we would be able to fly to their community with a medevac team that could land safely. And in this case, we were able to, which is fantastic because sometimes it doesn't happen. And in this case, there's like a half-hour weather check required every time a plane takes off. And we only had a 3-hour window. So if you subtract a half hour from a 3-hour window, you have 2.5 hours. And then you add in a flight time of a half hour. So now suddenly within your 3-hour window of getting there and then taking off, you've lost an hour. Now you only have a 2-hour window. So anyways, they were able to get there, they were able to land, And now Mayo doesn't have an airport that you can land on in the nighttime or at the lowest point of the sun being up. So it has to be high enough that the pilot can see the landing strip and land. It also has no like defrosting operations. So once the plane lands, the paramedics have to come off and then the plane has to circle above so it doesn't get too cold to be able to take off again. So anyways, we're an hour and a half in, the plane has landed, the paramedics are off, the plane is circling, and the paramedics actually have to go to the person's home to pick them up because the nurse was on vacation and there's only one nurse in Mayo, so it's not like they could go from health center to airport to onwards. So the paramedics walk to this person's house because there's no ambulances available. They're able to, we call it packaging a patient. I'm sure there's a more appropriate term, but they're able to package the patient within 45 minutes. So now it's been an hour and 45 minutes. You have 15 minutes, like plus an hour to get back. For the plane to land, well, so the paramedics are not able to communicate with the pilots in the air. Neither are the dispatchers. So what happens is the paramedics radio the dispatch center calls their dispatch center, and their dispatch center radios the pilots. And that in itself takes, 15 minutes. We now have like an hour left on this entire operation to get this one child on on a plane to get them to Whitehorse. So eventually all of this happens. The plane takes off in the nick of time to be able to get back up in the air. And there have been times where the plane lands and the paramedics and the pilots are left there until the next morning where maybe they can take off again. So this patient gets on the plane and you're probably like, oh, fantastic. They can get to Whitehorse and get their care. That's not how it works. There are no pediatric care practitioners in Whitehorse. So how it works is they have to go to BC Children's, which is about a 3.5-hour flight. Now you're probably thinking, oh my gosh, they're on a plane. They can fly straight there. Incorrect. So one of the other things you have to consider is pilot flight time allowances and paramedic flight time allowances, and the fact that receiving institutions can only receive from other hospitals. Now the paramedics went and got them the patient from their place of residence. BC Children's or any receiving institution external to the territory does not allow that to happen. So they had to take off in Mayo, land in Whitehorse. The patient had to get off the plane, admitted to Whitehorse General Hospital. We then had to call BC Children's to make sure they still had a bed available because we had called at 1 a.m., but beds go fast, as you may know. So anyways, at this point, the child was checked in Whitehorse General Hospital. And by checked in, I mean they were in the emerge hallway, was their described location in the hospital. And remember, this kid is critically ill, has a timeline associated with a positive outcome. They need to go. And in this case, they were there for about 2 hours because that's when the next pilot crew was going to go back on. And the paramedics in this case had been on shift for 16 hours, which is too many hours for them to be operational. So we had to wait for new ground paramedics, new flight paramedics, new flight crew. The plane had to defrost and refuel and then be able to take off again. In this case, the perfect scenario happened where the next or the same day at 1 p.m., so 12 hours have elapsed, we finally had a plan of, okay, we have the paramedics, we have the plane, everything is fueled, there's a bed waiting. And then the paramedics called in sick. And that was it. Like, the patient was able to leave 2 days afterwards. So they were able to gain care, but not within the window of a positive outcome. And that's one of many stories. Like, I could tell you about patients that swallowed a button battery like an hour out of town, and the best advice I could give them was drive as fast as possible, because that was it. And that's a very common occurrence for people who not only live in the north, but other more northern or remote regions. Okay, so for many families, treatment means temporary relocation, and that can mean things like months away from home, siblings staying behind, and the loss of support systems, as well as parents navigating housing in an unfamiliar city. And also children beginning treatment in an environment that doesn't quite feel like theirs. As we all know, and I don't have to tell you that pediatric care is already very destabilizing, and geography changes the context in which that destabilization happens. So my research asks whether geographic distance influences things like time to treatment, time to diagnosis, and event-free overall survival. So this is a developing feasibility analysis using CIPSE data, and I'm examining whether measurable outcomes emerge at a national level. I don't quite have final results yet, but it's about understanding what we can measure and how we define exposure. So if distance increases burden, then coordination becomes very critical. So referral pathways determine how quickly a child reaches specialized care. For example, the example I gave you, 3 days sometimes, maybe more. So travel support programs can reduce logistical barriers, but systems vary across provinces and territories, and that variation in itself is very informative. In remote regions, relationships between institutions matter deeply, so shared accountability matters, and informal coordination often supplements formal systems. I can't tell you how many times we called any institution receiving to see if there was a bed available, and we were told, if you take a repatriation, maybe we'll swap a bed for you. Like, that's how it works, and it's not to blame one or the other, but that's just what the system is. So flexibility within like rigid structures becomes essential, and distance is structural, but so is coordination. Administrative data captures timelines and survival, but it doesn't capture emotional displacement or cultural separation, or things like what it feels like to leave home for months, especially when home is thousands of kilometers away and not maybe a kilometer or two or down the street. And these gaps matter. The quantitative patterns need qualitative context. So if distance does not always produce worse outcomes, what's buffering it? What referral models could be scaled? What support structures are transferable? And what remains invisible in current data sets? How far should we define too far? So Canada's geography is fixed, but how we design systems around it is not. So centralization and equity must be considered together. And if care is centralized, then engagement can't be peripheral. Northern perspectives are not niche, they're instructive, and geography is a feature of Canada. Equity depends on how we intentionally respond to it. So the national data helps us understand patterns in diagnosis timelines, treatment access, and outcomes, but data alone cannot explain what families actually experience and what care requires, and when care requires relocation, what does that actually feel like? The second part of this work, and the primary focus of my thesis, will involve qualitative interviews with families from northern and remote regions of Canada. And these conversations will explore how diagnosis pathways unfold, what relocation during treatment feels like, and how referral and coordination support systems shape those experiences. The goal is to understand what the numbers cannot capture, which is the lived realities behind geographic access to care. And that's everything.
Actually, that was really passionately delivered and a really important study. The first part, the quant part, that's part you're doing as part of your MSc, or is it's already done?
We're in the process of like the early process of it, but we're hoping it'll inform the quantity of people and the reach of like remote and northern folks.
Okay.
And if there are trends in actual like treatments and like what does it look like for people who are far, or like, and how far do they need to be for things to deviate? And is distance something measured in kilometers, or like if you have to take a plane, a train, and a car to get somewhere, but you're still like close, like what does that look like?
I was just curious about how you're measuring time to diagnosis.
That is
It's in there.
yeah, like I think that's something measured.
So time from first healthcare contact to time of diagnosis.
What do you mean in there, in SIPC?
It's in SIPC.
Okay, defined as time from first healthcare contact being primary healthcare contact
Any healthcare contact.
as reported by parents. Or
As
as
captured
failed.
by data managers at the oncology site. So many places will have identified it as, you know, first presentation to a family doctor, first presentation to.
But it's based on parental reporting or it's based on billing? I
Um,
ask because we're doing this in Kenya and it's been really tricky.
It's, I think it's mixed within the data fields. I think some provinces capture it one way and some provinces in another way. I don't know how certain people are about that data field, but I think as long as it's being done consistently everywhere, we can identify if you are, and this is the other piece that's been very interesting. Lots of us have looked at distance as a marker in some studies, but it's often an arbitrary cutoff of 500 kilometers or 200 kilometers. And this is asking the question in the opposite way. Like, is there a cut point at which these outcomes start to differ? And if they don't, this is Ayesha's question often to me, is if they don't, what is buffering that? Like where, don't just look at it from a deficit perspective, but what is it in the systems, in the communities, in the support that's available that is allowing those things to be the same if it takes you 3 days to get out of your community?
And there are like communities have grown protective features for themselves because they've had to, right? Where it's like if it takes X amount of days for them to gain treatment, like why would the outcomes be the same when they shouldn't be? Or that like why
When there's so many features against
yeah. Like if they're fighting everything like in the system that's supposed to help them, like their outcomes, and they're still doing well, like how are their communities protecting them and what does that look like?
That part makes a ton of sense to me. I think that's really important. Has been little asked. Yeah, just really, I was curious about the specific definitions of time to diagnosis because I think it's varied in the literature and
And I think it is very probably also in the database.
interesting.